It is just a huge honor for me today to be podcast entering Santosh Patel, MHA, that stands for Masters in Healthcare Administration, and MBA, which stands for Masters in Business Administration. He's the president and co-founder of Complete Specialty Solutions, CSS, in-house dental specialists, adding oral and maxillofacial surgeons, periodontists, orthodontists, pediatric dentists, or endodontist services for DSOs or independent offices. He is committed to driving collaboration between general dentists and specialists by providing a turnkey in-office specialty solution. With over 15 years of large-scale operations experience in both the medical and dental industry, Santosh and his team are helping DSOs, groups, solo offices thrive by addressing the needs expressed by patients for comprehensive in-house dental care. Complete Specialty Solutions provides in-house specialty solutions to general dentist offices through their unique combination of clinical, business, and operational support delivered as an integrated and turnkey solution. Their highly experienced team has activated and scaled in-house solutions across all major specialties: oral surgery, orthodontics, periodontics, endodontics, and pediatric dentists in both solo office and large DSO operations during the past 8 years. More than a consulting or staffing solution, Complete Specialty Solutions actively manages all aspects of specialty integration and related operations, from support with marketing, case selection, and treatment planning to billing, insurance processes, as well as procurement and logistics related to all necessary supplies and equipment. In addition, Complete Specialty Solutions utilizes only board certified or board eligible specialists that are led by clinical directors in each specialty that proactively manage quality, patient, and GP satisfaction. Complete Specialty Solutions, I mean, my God, I could read on and on. I love what you're doing.
You're on the website, I assume. Yeah, thank you.
No, I do my homework and make my notes, but by the way, if you're in dental kindergarten school and you're wondering what is this about, number one, I don't do commercials. Did you pay me to come on the show?
No, I did not. No.
What?
Yeah.
The check is not in the mail?
At least it hasn't cleared yet. So
well, I'm going to send my 4 grandchildren in Texas up to your house and start knocking on your door. But no, the reason I do this is because there's just 2 facts that you can't deny, right? You know, an inconvenient fact is this. Number one, there are 1 million attorneys in the United States. And if I do a root canal as a general dentist and it fails, and you go to a personal injury attorney, what he's gonna do is he's gonna try to send the case to the board and see if the board rules against it, and then he's gonna do a trial. If it's a specialist, they throw out the case. They go, look, you know, they say 10% of Americans are completely edentulous with no teeth at 64. 20% are 74. So if we get Santosh on the witness stand and he's all crying about losing a bicuspid, and 1 in 5 of the jury don't even have a tooth in their head, they're going to say, Santosh, get over it. You lost a tooth. I don't have a tooth. They don't go after specialists. Then number 2, if I do the root canal in my office, they'll give me maybe $700. But they'll give an endodontist $1,200. So if they're giving the endodontist $500 more and it doesn't get sued, and then you have this little inconvenient thing about all major religions. My oldest 2 sisters went straight into the Catholic nunnery after high school, and my oldest sister, Rome put her on translation. So she had to learn Greek and Latin and Aramaic and all the languages. And she said in every major religion she's ever studied, the only thing it has in common, not the name of a person, a city, a place, a town, it's only the golden rule: treat other people like you want to be treated. Then I started thinking about myself. Well, when I need a root canal, I'm not going to let a general dentist do it. I'm going to go to an endodontist. So it's kind of like, I want to be treated by specialists. The insurance is going to pay 30, 40% more, and the lawyers aren't going to sue it. So what you're doing, it's just the obvious what everybody's going to be doing in the future. Am I wrong, or did I miss something, or misinterpret it, or what do you think?
Yeah, I mean, obviously there's a lot of benefits on that side. I mean, we do believe general dentists are going to continue to work to the top of their license. You know, I may be a slightly biased. My wife's a general dentist. She does do some root canals. But no, I mean, I think there's
Man,
definitely,
you are a genius. Instead of going to dental school, you just married your own dentist. Man,
yeah,
that is
that was the plan. That was the
that is
plan.
slick. That is slick. I should have thought about that.
Yeah, yeah.
But was it so I like that. You say general dentists should work to the top of their license?
Yeah, absolutely. I mean, and we believe that, right? I mean, even though I think you talk to specialists still believe that as well. There are cases that general dentists feel comfortable with and they have confidence in doing and completing. There's some cases that just make sense to be able to refer. We call it refer in, right? Because our team's there. But also from an efficiency standpoint, chair time standpoint, economics, like you addressed. I mean, there's a whole multitude of factors that really create a value prop for the general dentist in the practice. But yeah, no, I mean, I think there's definitely enough opportunity, enough cases where general dentists, serve those as well as learn from our specialists that are there.
Well, I told you what I saw that the million attorneys don't go after
Mhm.
specialists. The insurance pay you more and
Yes.
treat other people like you want to be treated. I would. I mean, look at my ophthalmologist friends. One of them does just glasses. One of them's an
Hmm.
MD. One of them only does glaucoma, and one of them just does retinas. Well,
Right.
I don't want to go to a retinal surgeon to get my wisdom teeth out. I mean, I
Right.
would want a specialist. But I noticed you're doing oral surgery, ortho, perio, endo, and pediatric, and there's actually 12. There's actually oral surgery, endo, perio,
Hmm.
pediatric, ortho is what you're doing. But I don't
Right.
see you talking about prosthodontics, dental anesthesiology, oral facial pain, oral med, oral path, oral radiology, dental public health. So,
Yeah.
is there just not enough demand for that, or what are your
No,
thoughts on?
I think it makes sense for us and our business. So we've been active at this just a little over 3.5 years, and focusing really specifically on the four core specialties that we've focused on is the oral surgery, perio, ortho, and endo. And we are incorporating some MDs as part of the sleep apnea opportunities, and so that's another service line we're going to launch based on the needs that patients have. We also, in our
Wait, you
current
said
operations,
you said the four core dental specialties. Is that what you called them?
those are the four core that we focus on today. Correct.
But is that and those are oral
Or-
surgery, endo,
Oral
perio,
surgery,
pediatric?
not pediatric. So oral surgery, endo, perio, and ortho.
Okay. So wow, I so pediatric dentistry didn't make it. So
Not
why
yet. Not yet. Yeah. I mean, we
so
think it will.
if those are the four core specialties that you're focused on, I would think with an MBA and MHA that means that's the four highest demand.
Those are the four. Well, pediatric dentistry is definitely in high demand, but the other four are definitely in the highest demand. It's also, the four that we look at from an ability to mobilize specialty, right? So we're mobilizing these services. So we look at the four specialties that make sense based on the demand, supply demand, as well as the surplus of specialists within densely populated areas. So, and also, as right, anytime you start something new, you try to be able to start it to a point where you can be more expert level in it and focus on the operational side and make that work before you start to really grow and scale in different areas. And so, we want to focus on these four first, but I think there's a lot of work already being done in these four core specialties for us.
Well, I don't know if you're well, I don't know how old you are, but I don't know if you remember Regina Hertzlinger. You and I have an MBA, but she has a DBA, a doctorate in business administration from Harvard University,
Okay.
and she wrote. She's the number one healthcare economist from Harvard, and I've had her on this show. She's just the smartest damn healthcare business person I know, really. I mean, she is just
Sure.
out there. And she wrote a book called The Focus Factory. This was 30, 40 years ago. And in The Focus Factory, what she did, and remember, she's just crunching data. She
Right.
found out something blew everyone's mind. The dentists always think, if I spend an hour on a crown and your wife does it in 30 minutes, well, your wife's just cutting corners. And do you know why Wendy's has square patties? Because they
Yeah.
don't cut any corners. And she's just rushing through and being a slack, and people would pride in how long they took. And
Sure.
Regina showed that in the Focus Factory that the faster you do a procedure, the higher it was. And she started with something routine, like it was a what's it called, a hernia operation. And
Okay.
she said that when you only do one thing, and you know exactly what the hell you're doing, and you've done it a million
Yes.
times, that when the entire hernia operation of doctor time was under 10 minutes, they had less than like a 2% 1 month failure rate.
Complication. Yeah.
But by the
absolutely.
time it got to 20 minutes, it's like a third of them failed.
Mhm.
And you know, I see that in dentistry. Like they'll a filling will turn into a root canal. And then halfway through and then 3 times in the root canal, the assistant's got to take off her gloves and leave the room because the doctor asked for something like an apex locator or, you know, something that's just obvious. I mean,
Right.
I used to get so mad when my assistants would leave the room. I said, how would you like to be in the hospital getting brain surgery? And every time the damn neurologist asked for something, the nurse had to leave the room and go find it in a drawer or an autoclave. I said, you don't know what you're doing. So I used to tell the patient to cover the ears. I had one of those ear sound things from the NBA when I had my season tickets to the Phoenix Suns to see Charles Barkley. And I'd lean back in the hall and I go, and the office manager running here. I said, look, 25 cents of every dollar goes to labor. 10% goes to labs, 6% goes to supply. I'm doing my 18 trillionth root canal. Why does she have to leave the room? And she'd say, well, we only have one of these. And I'd say, well, we have 8 rooms, so get 8 of them because every room is a Boeing 737-300, Southwest Airlines, Herb Kelleher. My God, every airplane is the same. Everyone knows how to fly it. Mark Costas taught me a decade ago. He said, if I go into your 8 rooms and I open to the 3rd drawer from the top, they all have to look the same, or now nobody knows where anything is. I hated the fact that when I go over and stay with my children, I have to rearrange all the dishes in the kitchen and the pantry because, okay, you got cups in 3 different cabinets, you got silverware in 3 different drawers. I have very limited brain function, and I'm going to have to organize this because I'm not going to open up 3 drawers every time I need a fork. I'm going to make this.
Less is more. Less is more. It's
and my gosh,
helpful to have a map.
So you know how many general dentists have spent 1 hour trying to get out 1 impacted wisdom tooth, and the oral surgeon takes out all 4 in under 10. And endodontists, I mean, those guys do well. Endodontist is weird. I'll tell you what's really the weirdest thing about endodontists is when I got out of school, the big studly endodontists in Phoenix, they were all doing like 9 molars a day, and they were taking about 45 minutes to an hour to do them, and they were getting, you know, like bank for them. And then they got into microscopes and they became brain surgeons and neural surgeons, and it slowed them down. And now every endodontist who was doing 8 or 9 molars a day 10 years ago is now doing 4 to 5 molars a day, and they just keep buying more toys. There's this one machine that once you found all the canals and worked them all up for a 20, okay, I don't need any help after that, but they want to buy a saw and endo to start swishing and cleaning everything out. But anyway, they've really slowed down their productivity. Are all your endodontists wanting a scope when they go into?
Yeah, absolutely. Yeah. So we bring a scope in for all of our endo. I mean, it's, you know, we feel, you know, again, we have clinical directors over each of our specialties, and they feel that that's a standard of care, and that allows them to operate at a certain efficiency level. So we bring a scope. And again,
efficiency or quality. I mean, I see where it's higher quality, but it's not faster. I mean, I think the microscope.
Well, I think we've seen scenarios where the endodontist really just doesn't have to move, and instruments are handed, and it's orchestrated well, and it's coordinated well. Then it's very efficient. And I think
are they looking through it the whole time, or just the check before they obturate?
Many of them look through it the whole time. Yeah,
like the submarine operator. Yeah, and
I
that's
mean, they'll step back, let the patient settle in, but for the most part, once they're under the scope, they can have the right team, the right coordination with the instruments. It's a little orchestra. It's nice to watch.
I had one dentist for a long time that did everything through a scope just because of his back problems.
Yeah, absolutely.
He had really bad back problems, and the only way he could do it is sit completely straight, and he couldn't lean his head. But I want to tell you another thing. The most controversial article we ever had in Dental Town was a guy, Scott Perkins, who wrote the 15-minute root canal. And it's kind of funny because the endodontist, in fact, the endodontist I think it was in Toronto, banned me from speaking in Toronto after I wrote that. And what people don't realize that every time I've ever been banned, I think it was Rhode Island, Missouri, and Toronto. Every time I got banned, the rumor got out and got me 10 more invitationals. So it's very, very good for your reputation to get banned. I'm trying to get arrested with 3 wildly, scantily clad women at a bar at midnight, but I still haven't been able to figure out how I'm going to do this. But I just know it'd be good for their reputation. But my gosh, I think that endodontics is crazy. But anyway, what the guy was saying actually was a repeat in history from Omar Reed. Omar Reed told the prosthodontist, he called the 90-second crown prep. And every prosthodontist said, the late Omar Reed, horrible, fast shit. I mean, who the hell would do a crown prep in 90 seconds? And of course, they didn't listen to a word he said. What he said was, the burr is only touching the tooth for 90 seconds. What they do is they drill, rinse, dry, look. Drill, rinse, dry, look. Drill, rinse, dry, look. Drill. And Omar said, quit it. Take out the interproximals. Take out the occlusal. Go around 3 times. Do not stop. Just drill the damn tooth. And he would show it at a live in his office, and he would actually drill the preps in 90 seconds because he never stopped, and he did it. And then, of course, when he rinsed, dried, and looked, he might smooth it out or some touch-ups or something like that.
Sure.
But what the article by Scott Perkins, who's a dentist, amazing dentist in El Paso, Texas, he called the 15-minute root canal because what he did is he went in there with a stop timer, and an endodontist would take out the 300 RPM night tie, and he'd put in a 15 file, and he'd drill for like 1 minute, and then he'd take it out, and he'd unhatch it, and change the file and put it back in and get it all ready. And by the time he put it back in the tooth, he's wasted another 3 minutes. And what Scott did is he went in there, and before he started, he had 4 slow speeds. And they already had the 15, the 20, the 25, the 30. And as he was using one, they were changing the one in front of it. And he would pick up the 15, bang, 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 put it back, pick up the 20, bang, bang, bang. And he just did everything. It was a logistics symphony, and he had all the equipment. Everything was ready to go. The assistant didn't have to leave the room. And every endodontist has said, they all just looked at it and said, well, if he's doing a molar root canal in 15 minutes, he should have his license taken away. Hell, when you're doing a root canal number 8, I mean, first of all, your assistant could do it drunk while you were holding her hair and she was throwing up in the bathroom. I mean, how would you spend an hour on an incisor root canal? I mean, these people that spend 30 minutes preparing a tooth, I could drill every tooth in the arch to the gum line if I was to drill for half an hour. I mean, I don't even know what I'd be drilling. So the specialist, where they are amazing, is in attracting and retaining dental associates, because you get some kid out of school, they'll want to work for me if I got specialists rotating through there and they can go assist all these specialties. But how is your business going? You're talking about the top 4 core demands are oral surgery, endo, perio, ortho. How's it going? And are you mostly, what states are you in?
Yeah, so the business is going well. I think there's obviously a lot of opportunity both in the solo and DSO space. We do focus on the 4 specialties there, and our opportunity has really been able to serve the patient, right? The patients are asking for it. If you take a step back and think about buying habits from patients, again, why do people shop at Super Target? Why do they shop at Costco? I mean, they want everything in one location. They know the way the parking lot looks at an office, and they feel comfortable with how all that's coordinated. So we want to be able to mobilize this service. And, so we started out in Texas, really just Houston and Dallas. And from there, we've grown out to Austin and San Antonio, and we're now expanding into Florida as well as Philadelphia. So, knock on wood, business has been good. We typically work in more densely populated areas. That works well for us to be able to recruit both specialists as well as clinical RDAs, which is incredibly important for us. But that's knock on wood. Things have been on the upswing for us so far. There you go.
You said you're in Texas now, so you're starting like Southwest Airlines. You're all Texas, but then you expanded to Florida and where else?
Philadelphia. Yeah.
Philadelphia. That's a state, isn't it?
And we're in Nashville as well. So we're in Nashville, Tennessee.
So you're in 4 states.
4 states.
But please explain that. I mean,
Yeah.
Texas, Florida, Pennsylvania, and Tennessee. Why
Right.
those 5 states out of 50?
So I'll take a quick step back and describe our model, right? So in addition to the specialists, who are again all board certified, board eligible specialists, we have our own clinical RDA team that we employ within our organization. So it's a full team. Typically, each specialist gets 2 to 3 clinical RDAs to support them. And we bring all the supplies. So we, transport all the, down to 4x4 gauze, right? So I mean, we bring all the supplies and equipment, crash carts, everything that's needed to be able to provide these services. So in order for us to go into a new market, in addition to kind of the supplies and equipment, we have an operations team that really is there to help support the flow and the function. And we have a remote shared services team. But in order for us to go serve a new market, it's important for us to have, a group size enough that allows us to go out and employ specialists and have them on our team and bench full time and be able to kind of serve. So it's always been our land and expand strategy. So we work and partner with groups to be able to get into a certain market, and then we can serve the greater market from there.
So your specialists are board certified or board eligible.
Mm-hmm.
Is this to first of all, why is that? Where did you come up with this strategy? Why?
Yeah.
Why did you decide to do that?
Really, we wanted to focus my background, I came from the medical space, right? So I built large multi-specialty physician groups for 2 large health systems. And, we always brought in specialists to work with our primary care doctors. And in the same suit, we wanted to do something similar in the dental space. And as part of our due diligence and education and how this model works, we found out that a lot of specialists just were opposed to the traveling model, right? They say, hey, I don't want to do that. We don't think it's safe. We don't think it's right. So we dug deeper and we started to ask specialty practice owners, well, tell us a little bit more about this. And they say, we would support something where we knew it was board certified, board eligible specialists where training and residency programs are consistent, even though programs across the nation are not consistent, but overall there's certain standards and expectations and through their training. And then being able to then say, okay, well, now we understand that this is essentially a hybrid model, right? So many of our specialists own their own practices. So they can also preserve the specialty, right? So the goal there is we only work with specialists and we preserve the specialty, which has allowed us to really, recruit specialists, right? So it's kind of creating that network of only specialists who support specialists, and it's our own internal network.
So I'm trying to get the logistics right. So you're saying the specialists did like to travel from office to office, or they didn't like to carry their stuff with them? They wanted it at the office. What? I'm missing that.
Yeah, no, I think, so some of the specialists, in order for them to travel in the past, it was just becoming a logistics nightmare for them, right? And so in order for them to actually go into the offices, but yeah, I mean, when specialists were traveling in the past, the reason why they quickly stopped traveling was because either there was miscommunication, lack of communication, disorganization. They show up and, really they're flying blind on what they're doing that day, right? So there is just concern on, number one, is this right for the patient? Is it a good use of everyone's time? And how stressful and frustrating will this model be if, things don't change and things don't improve? So what we found was a lot of those specialists and a lot of our clinical directors actually used to travel. And then they open their own practices. And then they come back and travel, but through our organization, right? Because we've really addressed those pain points and frustrations. And so, does that help answer your question?
Yeah. And well, first of all, when you started Complete Specialty Solutions, why? What problem were you solving?
Yeah. So, you think about, so again, my wife's a dentist. I was pulled in on a Saturday to help her with an emergency patient, right? And when she's referring out the patient to an oral surgeon, the first thing the patient says is, well, why can't I do that here? Right. I mean, that was the very first comment the patient said. Back in my mind, I'm thinking, yeah, well, why can't she do that here? And so we start talking about that. And really it's because, well, why, how are we going to mobilize the specialist to come here? And there's a lot of logistics that's involved. There's a lot of coordination that's involved. And well, we did it in medical, right? I mean, on the medical operations side, we knew that was a huge patient satisfier. So that's kind of how some of the idea was born, is how do we, number one, bring operations into it, but number two, we built our own technology platform to really streamline that communication. So our specialists, they're not flying blind. They know, going into an office the next day, they can pull everything up on their cell phones, images to patient medical history. Everything is coordinated to make sure we're really providing the best patient experience. And so, the problem that we're solving is, well, why can't I do that here? And when we go and talk to any office, that's usually, you ask any of the clinical RDAs, the hygienists, they hear that comment 2 or 3 times a day when their patients are being referred out. So that's really what we want to address. And obviously, there's upside. The general dentist is, there's economic gain. All right, they're able to retain a portion of those profits that are typically referred out. But really, what we're finding is general practices and DSOs. Yes, the economic gain is wonderful. They really want the patient retention side. And that's a bigger component now, is how do we make sure we retain our patients within our practice? We work so hard to go attract them to come to our practice. How are we going to retain them? So that's, again, addressing those needs.
Okay, so I see. Come on. We have 300 years of retail. I mean, you go back 300 years. You go back to Adam Smith, 1776, The Wealth of Nations, and basically 300 years ago, if your dad had a little 10-foot by 10-foot shop and he lived above it in a shop house, the next generation would take out your dad by being twice as big. And then the next generation get twice as big. And that kept going for 300 years until Walmart, Costco, and Home Depot said, you know what, 250,000 is too damn big. Now you're like going to some NFL game or something. It's too big. And about 5 years ago, Walmart started closing down some of the ones that are too big. Sure. But, when I lectured the first time in Sydney, Australia, I couldn't believe it. I felt like I was going back in time. I was staying with a dentist. And to go get dinner, we went to a butcher and got the meat. We went to a baker and got the bread. We went to vegetables. We went to 5 places. And I was telling him, I said, in Phoenix, this is all would have been in Safeway. And, right. But I liked it there, and I liked it in some of these old countries, like you go to Italy and you'll find some village where it's still that way.
Sure.
But we see obviously that clear choice when they added the surgeon plus the prosthodontist, plus the lab tech under one roof. They were doing, 18,000 arches a year, got sold 5 times, and finally Bob Fontana of Aspen bought it, which makes total sense because he's the only one where he's branding all the stores the same and he's going where they ain't. He goes to where the Medicaid providers are because all the GPs are chasing the 60,000 median household income and up with insurance. Sure. And there's no one down there in the Medicaid market. And he's got his removable guy. So he's got a dentist and now he's got this. So all those 800 locations, if anybody's asked about all on 4, he can funnel them to Clear Choice. I see the same thing with pediatric dentists and orthodontists. If 100 kids are taken to the pediatric dentist, 90% are going to be taken by moms, and every mom's going to say, is little Santosh going to need braces when he grows up? And then she's going to say, oh, well, you need to fill out a form, go down the street, meet a stranger. And so if I see a pediatric dentist open and an orthodontist open, that's 1. If they open together at the end of the year, it's 1 + 1 = 3.
3. Yeah.
And then I want to tell you my idea, but I don't want you to steal my idea. I mean, I haven't patented it yet.
Are you adding oral surgery to that?
No, I'm going to do geriatric dentist plus a crematorium, so Grandpa can finally get the smoking hot set of teeth that he's earned.
Sure.
Earned, get it?
He
earned it. And so when are you going to add geriatric dentistry, and will you add crematology with it?
I'll maybe let you run that side of the business, and welcome to I'll partake maybe in a couple of years when we're ready to scale that component. But
what I don't understand is what's in it for the specialist. I mean, so where I was going is, well, this completely is obvious to the retail patient.
Yeah.
I mean, I only want to go to one place. I wouldn't want to go to 5. I wouldn't want to go to 12 different places to have something done. But what's in it for the dentist?
Yeah. So obviously we know the benefits for the general dentist, right? So what the value prop for the specialist, a couple things. One, we know that less than 40% of patients actually go to a specialist when they're referred, right? So that's 60% of patients.
Wow. Is that, I did not know that. Less than 40% of patients go to the specialist when they're referred.
Right. And so, what do you do with those 60%? The ones that have been identified from the general dentist that need treatment. Either it's because it's a new office, it's a new location, they don't accept insurance, or they don't accept your insurance. There's a lot of factors on why a patient just doesn't go, and we saw that again in the medical world. It was prevalent. So, we addressed, okay, well, there's a subset of population that's going to go to the specialty office, and we believe they should, right? So we focus, when we do in-house specialty services, we focus on right case, right place. There's many cases that need to go to a specialty office, and they should go to a specialty office. And then the other component is, again, the specialists, many of them, if they're associates and they're not practice owners, they don't have to incur overhead. That's a significant component. They get out of the gates and start earning with the right mentorship or the right guidance. And they're fed an opportunity. So they step into a practice when it's organized well, when it's set up correctly, when there's pre-op instructions taken care of for them, medical history, med clearance. When those items are taken care of for them, they're comfortable and their level of stress is reduced, and allows them to really produce at a great level to be able to then go back. Again, if they have their own practice, they can still continue to serve their practice on those other days. Allows them to have incremental income, right? So specialist owns their own practice. They want to consolidate down their schedule to 4 days a week or 3 days a week and work 2 days a week with us. And that's incremental income, So, that coordination with the component of transparency on the technology piece that we've built, that's really been the value add. These are structures where the specialist walks in and these are patients that are lined up for them. So, from that sense, it's a huge economic gain.
So, how do you merge practice management software when they're on Dentrix and EagleSoft and Open Dental? And I mean, there's 40 different software companies, and then a lot of the specialists have, orthodontics, there's Cloud9. I mean, they're all so fragmented, Endo, TDS, How do you solve that problem?
Yeah, so our software right now, it's essentially built off of a referral portal, and then the practice submits a few items into that portal, and then that's our database, right? And so we're in the process now of going through some integrations and APIs with 3 of the more common platforms, right? Open Dental, Dentrix, and EagleSoft, but there's some practices that we use that have cloud-based software, which is incredibly easy for us to navigate through and operate with. But the beauty is we're able to build our own software. My partner is a healthcare tech entrepreneur, right? So he was in the healthcare space, focused on referral management, operations, and really kind of patient engagement. So we're taking the components of what our specialists need, and we'll be able to extract that out and be able to kind of continue to provide that information to our specialists in a succinct manner.
So, this month, we're at May 19th, and this month, 6,500 kids are going to graduate from dental kindergarten school. Yeah. And they're going to come out of their little protective game reserve into this brutal reality.
Yeah.
And 90% of them are just going to get associate jobs at DSOs until they get some experience, whatever.
Sure.
But when they go open up their own practice, do you have any recommended practice management software of everything you've worked with? Like you talked about Dentrix, EagleSoft, Open Dental. Any of those anything you would recommend for a general dentist kid out of school opening their own office from your background?
Honestly, I think Open Dental has been pretty simple to use. It looks like they're going more cloud-based. I mean, again, we've worked with all of them. I would say, truthfully, there's not one I would not work with. I think all of them have had their own kind of pros and cons. And it's just the comfort level. It's making sure they have the right training, I think, on the onset to make sure they're comfortable with it. But Many of these cloud-based softwares, practice management solutions, are integrating different software solutions that are third parties that offices are having to pay for separately, right? So text reminders, online forms, integration, insurance verification, those kind of components. So I would really just challenge these folks to kind of take a step back. And there's already so many forums out there that are discussing this, but the big ones are the ones that are out there really making innovations and changes to their platforms to kind of serve the need. But everyone's been pretty simple. I mean, they're all pretty much the same to some degree, right? But it really comes down to user-friendly and the training from the beginning to really know what they have in front of them.
Now I'm going to ask you a question that's going to make you regret coming on the show. It's Dentistry Uncensored. I don't like talking about anything everybody agrees on, but you said you come from the medical world.
Yeah.
The medical world, just in the United States, I can't do your brain surgery and bypass and do the anesthesiology. Every hospital in America says, nope. We have the data. One guy needs to be staring at the anesthesiology and one guy needs to do the surgery. We don't mix that. It's always mixed in dentistry. It's always mixed with oral surgeons, periodontists. We have general dentists that go take a class at the Holiday Inn, and the next thing you know, they're doing IVs. And England banned it. They told their surgeons, no, you're not going to do this because even though the death is really rare, it's still statistically significant. Now, they're going to argue, but anyway, I don't want to go into that, but what do you do when your oral surgeons and your specialists want to start an IV? And then what does this say to the dental anesthesiologist said, hey, dude, we're a specialist too. And what you're doing is not even legal in every hospital in the state of Texas. So how do you wrestle that issue?
Yeah, no, I love that, right? I mean, again, we have, so disclaimer, not a clinician, right? But we got our clinical directors are the ones who help drive this. And we're seeing more and more, it's becoming more and more common. We are bringing MD anesthesiologists in. We are bringing CRNAs in to help support the specialist. It's not just the oral surgeon who's providing, the sedation services, emergency care, and treatment. It's making sure our teams are prepared for it, right? So are we running codes? Are we running tests? Are we using old expired emergency meds to kind of practice and make sure everyone understands how to break an ampule and be able to pull the FBAs like they need to? Those are steps that we take to be able to help provide and enhance that safety element that really doesn't really occur, at least what we've seen in that model before, right? So it's taking it to the next level. But I think overall our oral surgeons have received additional training within their residency program. I'm not familiar enough on the general surgery aspects of medical, but I think oral surgeons actually receive more training when it comes to anesthesia as well. So within their program. So I think there's an upside in that component, but we also want to err on the side of safety, right? So CRNAs and anesthesiologists as a complement to our business is something that's.
And what I want to say to that is, like the first president of the American Dental Association, the first two were DDS MD. And the president of the American Dental Association right now is an oral surgeon from Arizona. He's a DDS MD. And a DDS MD doing IV sedation, that is so different than a general dentist who took a weekend class at the Holiday Inn. And when I've been a dentist since '87. In fact, this is May 19th and May 11th, 8 days ago, was my 34-year anniversary. But I started a media company in '94. I started my own dental magazine, and that made me a dental journalist. And so I have these malpractice. Lots of companies send you all these press releases because they want you to get the message out that helps their industry. And every time, I always get the last month's settlements for all these malpractice claims. And every time it's $1 million more, there's an IV in the arm and someone died. And it wasn't a DDS MD. It was always a general dentist doc in the box. And they get so mad at me when I say this, but God, you got enough stress in your life. Look at you. You married a dentist. How much more stress could you have walked into by marrying a dentist? What was your next best idea? A hyena, a kangaroo? The last thing you need to be doing is putting people to sleep And if you do that from age 25 to 65 and one person doesn't wake up, you just ruined your whole life. You ruined the patient's life. Every dentist I've ever known that accidentally killed someone, they never smiled again. And
raise their psyche.
And one of my really, 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 really good friends, close. I mean, I almost consider him like a blood brother from Kansas. And he pulled an eye tooth. And, that's the Bermuda Triangle there where the valves go back in the brain. But he thought it was routine. No big deal. Didn't put antibiotics. And she showed up in the hospital a couple days later, and she got a brain abscess, and she died. And I swear to God, it literally killed him. He was never happy. His stomach was always upset. It's just so bad. And that was, there's probably every dentist listening to this podcast has pulled one tooth between the canines where they did not give him a script of antibiotics. But if you're the guy that does that and they die, and God, anesthesia, like out here in Arizona, we've had twice from the same place in the same clinic at Yuma, 3 years apart, where they did an IV on a child and the child dies. And I think
honestly that's one benefit of our services, right? So there are a lot of general dentists who want to continue to grow their skill sets. But they are engaging our teams and our specialists to come in because they can render that care, and that's in that anesthesia. Now, we don't offer anesthesia for the general dentistry side, right? We're not sedating the patient so they can do fillings and crowns or anything of that nature, because our specialists want to make sure they're in control and full control of the airway. But we want to make sure ultimately we're creating an environment that's safe for the patients the best we can. And again, it's not just the training of the specialists, right? I mean, there are so many different components that go as part of that. I think a lot of that belts and suspenders concept, again, comes from the medical world. So,
and I'm going to ask you another question that's going to get you in trouble with your own doctors. Okay, you can't get two dentists to agree that it's Wednesday. You can't get two dentists to agree on the same bonding agent. Every group practice, the dentists say to the lady from Burkhart, Benco, Shine, Patterson, they go, well, can you lower our supply bills? And like, there's 3 dentists. Can you use the same bonding agent, the same, can you use the same of anything? So they, herding dentists is like herding cats. And without meeting any of your clinical directors, I already know they have to be toothless lions because my dentist ain't going to listen to anybody. I mean, they're herding cats. How do you get a clinical director to get dentists to agree that at least we live on a round sphere and not a flat earth?
Honestly, I think it's just the fact that there are specialists talking to specialists. We've seen a big change, right? Like you initially would think, okay, there's ego that's involved and folks are not going to listen to one another. And I think when you sit back and say, okay, well, give me your perspective. What challenges have you heard? What are the concerns that you're seeing within your different maybe cocktail mix, of sedation meds? But we've seen a lot of our clinical directors, again, they're in their role for a reason, right? They're able to provide some insight and feedback, mentorship, but also they want to learn, right? So what's someone else doing? Maybe they've been doing it well for the last 4 or 5 years, and let's have that conversation, discussion. And so we've actually seen the opposite. I mean, not that everyone practices the same way. We're not pilots, right? Not everyone's trained the exact same way. But there's a lot of learning that goes on when you kind of build this network of specialists who, number one, understand that we're trying to preserve the specialty. And number two, they understand that we're coming at this with the right angle. We want to make sure, again, this is a safe environment. It's good for the specialty itself as a unit. Again, they may not have to agree on the exact same, cocktail mix, but I think they're open to have the discussion on, okay, well, do you think that gives you more exposure or risk versus trying this, right? Thankfully, we have not run into too many issues with that.
Okay, so now I'm going to read just questions that are posted today on these types of questions. He goes, under the forum, ideas to make your practice grow, under practice manager, ideas to make your practice grow.
Sure.
She says, adding specialists. I've recently come across the opportunity to bring a specialist into my practice, and while I'm really excited about the idea, I'm a little lost as far as how to proceed on the business side. I own a modest family practice near St. Louis. I'm the only dentist currently practice Monday through Thursday, but we are overflowing with new patients and recur exams. And one of my hygienists is willing to do Fridays to accommodate that need. Since we'd be opening that Friday, I also know a prosthodontist who teaches at the dental school who wants to work private practice on those Fridays. She'll also do hygiene checks. She can also place implants and do some surgical extractions and bone grafting as needed. I've worked with oral surgery in my office before, but that was when I was with a DSO, so they handled the business setup. Does anyone know how to get her credentialed as a specialist or how to make sure her treatment plans have the appropriate fee schedule attached? I don't want to just add her as a provider since then she will fall under my same fee schedule. For those of us who have in-house specialty, what is your payment arrangement? She will probably start July, so we have some time to figure this out. Thanks for the help. That's a lot of questions, but
A lot of questions.
that kind of sums up succinctly. How, she's going to charge different. Anyway, how would you answer any of that?
Yeah. I mean, so for someone who's doing it on their own or versus kind of the make versus buy, right? I mean, that's why we exist in our business, is because we found a lot of offices had those challenges. How do we get that first domino to fall, and what's the next step, and how do we course correct if this is not right? And then, now we have turnover, right? So now we got to retrain back from the beginning on how this works. And so, and what we've decided to do is we kind of go in first and say, okay, well, how do we make sure that the office understands what the specialty service can bring? So is there engagement at the office level? Do the hygiene, the RDAs, do the dentists understand what value this brings to the patients? Then we work on patient identification. So how do you identify the patients that can benefit? And then how do you actually have that conversation with the patients on how they can benefit with this? And then the coordination of communication, right? So the specialists, they want certain things. In our scenario, they want the imaging, the med history, and then we give it the demographics and we do a treatment plan with them. We coordinate with them, we make it easy for them. But that's essentially, we've taken on that entire operation function. We've gotten to the point now where offices want us to contact their patients to actually get them scheduled, right? Because what happens, employee at the front desk employee at the office calls the patient. Patient says, okay, I'm interested in my wisdom teeth extractions. What can I expect on the sedation? Well, the office doesn't know. Office doesn't know that answer, right? And so then the patient doesn't feel very confident in being able to provide or have this service rendered at that practice. So that's where our teams kind of come in and make sure we can address all those patient questions and concerns. And if we need to, coordinate a phone call between our specialists and the patient and do our curbside consult before they come in. And again, leveraging our technology to make that streamlined, but also making sure if we need to pick up the phone and call a patient, we can. But to address her questions, how do you do it all? It's definitely a lot of different steps that have to be kind of coordinated in one, but it's communication with the specialist, making sure there's buy-in from the specialist, understanding, does the specialist know what they want from a flow standpoint?
So another dentistry uncensored question, a brutal fact that we're all not going to agree on. Fee splitting is illegal. And what that happened is way back in the day, about a century ago, if every time I referred a patient to you, you gave them, a surgery, and I got 50% of that. Well, the epidemiologists are like, well, if I refer Santosh 100 patients and he's an oral surgeon, he's going to pull all their wisdom teeth, and the doctor's going to keep referring because the wisdom teeth cost $1, and Santosh gave Howie 50 cents, and they just said this is illegal. So the bottom line is this. If I refer to a local specialist on my street and ask for half the production, I'll lose my license. If I refer to another specialist in my own medical dental building, I'll lose my license. I can't fee split with anybody unless he's inside my office.
Yeah.
So why is it illegal everywhere on this flat earth except in my office? And then the question is, then a cynical bastard, which is at least 112% of all dentists are cynical bastards. They might be sitting there thinking, Well, Howie, if you bring an oral surgeon in your office and you're going to split the fee with them, well, now you're fee splitting to have these wisdom teeth taken out. So does the wisdom teeth really need to come out, or are you just fee splitting?
Sure.
So address the fee splitting issue, because I'm
Yeah. So
sure you've thought
so
about
so
it
it's
before.
we have, yeah. I mean, obviously, this all came really from the medical space, right? And all the kind of components of Stark anti-kickback. But the biggest component is in dentistry. It's considered a division of services. So we're providing a service within the office setting. It's a division of services. Everything kind of flows in one direction. We're not bringing new patients to the practice and then having those patients referred to us within that general dentist. These are patients that are seen and active patients within a general dentist practice that are then referred to our specialists. We're just bringing that service within the practice setting. No different than if the general practice hired an associate, and that associate is an oral surgeon, right? So, very similar in that capacity, right? It's just considered division services by definition.
And I want to say some feedback. I've heard general dentists on Dental Town say that most specialists hate freelancing. They want to do it in their own office. Okay, first of all,
Yeah,
that's a typical dumb thing. That's a broad generalization. That's like saying
yeah,
all short, fat, bald Irishmen are sexy. It's
yeah,
almost true, but
yeah.
there
Not
could be
bald,
one
right?
that's
Yeah,
not. And then this is the thing that's always it always irks me. They say, well, you're just bringing in a specialist because you're trying to make money and you're fee splitting and you're going to end up getting more teeth root canaled and more wisdom teeth taken out because you're doing it for money. It's like, oh, and who are you? What are you? Some volunteer? What do you volunteer at Gandhi's dental office in Transcendental? I mean, why is it always some dentist who owns
yeah,
her own land, building, and business, who's collecting $1 million, taking home $250,000? They're always the ones accusing
yeah.
everybody of doing everything for money.
Well, I'll
I
address the
mean,
first
come
question.
on, make me
Yeah,
throw up.
I'll address the first comment. In terms of the freelance specialists don't want to do it; they just want to do it in their office. That's right, actually. That's when we did our research. That's the most common response that we received, and
Was they didn't like it?
they didn't like freelancing, and so that's where we had
Okay,
to
explain to
dive
the kids
deeper.
what freelancing means to the kids in
So
dental school.
yeah, so that's when they're traveling to one office for one day and then traveling to a different office and rendering care in another day. And or they get a phone call and say, "Hey, are you available on Tuesday to come here?" Right? And it's kind of like dentistry on demand, which with specialty is very difficult to coordinate because there's so many different dynamics as part of it. So to that point, yeah, many specialists when they freelance, they're frustrated by it, they're stressed out by it. They didn't feel like it was conducted in a safe manner, which that is why we dug deeper. Okay, so why is it frustrating? How do we address that? Right. So that's really what stemmed our ability to kind of address that pain point. And oddly enough, which I think, so you think about who are our clients. So we have general dentists are our clients. We have specialists who are our clients, right? We have two of them. Probably one of the most important clients that we have are clinical RDAs, because if we can go out and recruit and retain our clinical RDAs, they're the ones who actually make our specialists' lives significantly easier. And by virtue of that, the patient experience is enhanced, and therefore the general dentist is happier, right? So we've started to really then focus on, okay, well, let's go focus on getting the right clinical RDAs, training them up, creating a training program to address that, and then reduce again the stress that our specialists are having in this kind of itinerant, in-house model. But to that point, I mean, we understood that was a very common response that we received. And again, if there's a problem, there's got to be a solution, right? So you got to be able to kind of dive deeper. And so that's kind of what we spent some time doing. I guess your second comment, which was on, more dentistry is being referred in that scenario because the specialist is there. These are actually cases, again, if you're looking at from an imaging standpoint, a patient flow standpoint, these are cases that are typically being referred anyway, or at least being discussed as part of the exam and visit. But the patients were just less than 40% of the patients were actually going. So many general dentists just became numb to the fact that, okay, well, if it's not in immediate pain right now, maybe we just don't send the patient. right? Whereas, how do we become more proactive in this treatment plan opportunity? And so I think we see more and more success in being able to have that collaboration and discussion.
And I just want to say one thing to the people who say, can you refer to your local specialist next door and get 15%
Sure.
of the production? And I would just want to say, however, if you were to pay for all the specialists next door's rent, rates, staffing, stock, administration costs, computer insurance, malpractice, computer
Right.
updates. That's a totally different beast than what you're saying. So you got to compare.
We believe in the hybrid. We believe that there is obviously a trend of in-house specialty, but we obviously believe that there is a need to have specialty offices, and I think you'll see less and less independent solo specialty offices. I think they'll start bringing in associates, and that's where it's worked well for us, where you have a practice that's 2 or 3 specialists, and a couple of them work with us on different days, and there's still access and need and availability for that practice, but there's also the hub and spoke concept. So we don't think the standalone specialty practice is going away, right? So we just think that there's a way to be able to integrate that and complement the trends of dentistry.
Okay, is this rumor or real? You never know on social media when someone says something and they don't have a footnote or they don't have a source. But a guy in Dentaltown says there was a GP in Florida who had another GP come in his office to do the oral surgery cases, wisdom teeth extractions with sedation. And one of the cases, the young, healthy patient didn't wake up. And he heard that since the owner doc was referring to another general practicing dentist instead of a specialist, that he was now liable for what happened, even though the guy that came in was an independent contractor. So my question is, again, why is this a big threat on Dentaltown? Because someone didn't wake up. And why did they not wake up? Because it was a general dentist doing, God dang it, just don't play with fire. If you need money that bad, become a stripper. Just be a stripper. Don't start sticking IVs in people. It's just crazy shit. And they're cracking down on this. Not just in the United States, they're cracking down in the United Kingdom, Ireland, Wales. All everywhere I go, they're really cracking down on non-anesthesiologists, and the lawyers are onto it. But anyway, so my question to you is several-fold. If I have if I contract with you, and you send in an oral surgeon in my office, and he kills 3 patients and a penguin, am I liable for all that, or is that the oral surgeon, or is that your company?
So obviously our oral surgeons have malpractice coverage and liability coverage, right? And that's important for us. And our surgeons are employed by us, right? So there's always associated, liability on any employer. But the practice is also, should at least have the specialist listed under their malpractice and their overall general liability insurance plan. And we educate all of our offices to make sure they're doing that. But thankfully, and knock on wood, we haven't had scenarios where we're putting ourselves in situations that are at a higher risk. But I think, as we know this with any industry and anything in life, right? People are going to sue just to sue. So I think anyone and everyone can be available to be attacked in that regard. But I think it depends on the states. There's obviously tort reform that also kind of limits the amount as well as the individuals. But there's also 3 folks that can be sued in that scenario. But there's a lot of different kind of scenarios there. But I think by having a specialist in the practice that has the residency training, kind of minimizes and mitigates some of that risk that's going to exist.
Okay. Then my next question is, your 4 core in-house board certified, board eligible dental specialists. Do 2 questions on that. What is, if you were gonna do any more specialties, what would be the next specialties you would do? But number 2, you're in Texas.
We are.
I was born in Kansas. I went to Creighton and Omaha and dental school in Kansas City, and 4 of my 6 grandkids live in Texas. And I'm just sitting there wondering about those people in Texas, Oklahoma, Kansas. Do consumers know the value of board certified versus not? I mean, is this on their radar, or is this something you're doing for your guys? I mean, how many people in Texas say to their oral surgeon, "Are you board certified?"
Yeah.
Is that our thing, or is that a real consumer thing?
Yeah, no. So I think it's more of our thing. But yeah, I mean, I think what we're focused on is primarily really residency trained, right? I think because what happens is when we first started our business and our model, we had a lot of general dentists who provide oral surgery services that would contact us and say, "Hey, I heard you guys have a subset of offices that you're serving for thirds and implants. We'd like to serve those." And I said, "Well, unfortunately, we're only working with specialists within this realm." And so when we would go out and start recruiting other specialists, that was one of the first things that they would ask is, "Well, who all is within your network? This only specialists or general dentists also within this umbrella?" So that's the biggest reason why we kind of have that claim. So do patients know? No. Is this something that's on all the flyers and marketing collateral to the patients that talk about the doctor? Yes, right. But is it really necessary for our marketing efforts to attract or to be able to show that to our patients? It's not the primary there. It's really priority for us to go on for our own internal recruiting purposes.
Okay, and then if you were going to add more specialties, which one would be? You're doing oral surgery, endo, peri, ortho.
Mm-hmm.
Which ones were on
Yeah.
your radar?
So the next one would probably be the pulmonologist, oddly enough, right? So sleep medicine is where we're looking at, as well as just MD anesthesiologist. So those are the next two that we would incorporate in. We would like to incorporate pediatrics as well. There's just a whole different level of organization and structure that needs to happen to make that specialty successful. I think getting the MD anesthesiologist in first before we roll that in is an important aspect of what we want to be able to provide.
And your website, if anybody has any questions, is called CompleteSpecialty.com.
It is, yes.
What are my homies going to find on CompleteSpecialty.com?
Yes, I mean, a couple intro videos on how our business model works, how we're really focused on the value prop for the general practice, as well as obviously a landing page for contact. We're currently in the markets that we're in: Houston, Dallas, Austin, San Antonio, Nashville, expanding out to Tampa, Orlando, and then different parts of Northwest, kind of Philadelphia. But it's really informational to talk about what value props we bring both to the general dentist, but also what value props do we bring to the specialist. And if there's any questions there, we'd love to be able to answer them. Our branding and our logo is really for the industry, and it's not patient facing, right? So when we come into a practice, we're not wearing big signs that say Complete Specialty Solutions, or they're not signing documents that say Complete Specialty Solutions. We're representing the practice in that regard. Obviously, we're hired as a contractor in, but our focus is to really be able to present to the community that we're working as one unit together.
So, my gosh, you've been amazing. Go to their website, CompleteSpecialty.com. Can you give any names of DSO brands that are working with you now?
I probably could. I don't know if I necessarily should right now.
Oh, it's Dentistry Uncensored, and nobody's listening. We're having a private conversation.
Yeah,
Rick
yeah.
Workman's never even heard of this show, either
Yeah.
Stephen Thorne.
Yeah.
Do you ever go home at night and tell your wife that she should have been a specialist? And how does that go over when you say that?
No, she enjoys it. I mean, she enjoys being a general dentist. She does take different CEs. She, completed a straight wire ortho course. She takes active CEs on root canals and treatments. She doesn't do straight wire ortho, but it really allowed her to kind of understand the opportunities and changes and modalities, as well as being able to have that conversation on a treatment plan for a patient, right? We kind of believe the more the dentists do, the more they are able to successfully diagnose. So we don't shy away from that, and practices where we place implants, we know the general dentists are going out there to get trained, and we're not naive. We expect it. So in many scenarios, the general dentist will schedule an implant the same day that our specialist is there to place an implant. So they have a backup. They have someone to kind of talk to about it, and getting them comfortable and confident, with kind of those simple cases, we found allows them to feel more comfortable in having that conversation with the patient in general. So there's a lot of collaborations. We can look at this from one approach and say we're just going to create a big divide, general dentists and specialists, and continue to widen that gap. Or we can realize that this industry is moving in the direction where there's more and more collaboration, and patients are asking for it. Right? You think about it: if you're having an implant placed and your periodontist stops halfway through, looks at the pin, takes the X-ray, and the general dentist comes in, so that's perfect. What is that level of experience now, and how is that enhanced for the patient, right? And so they know that there's a team that's focused on this. So there's definitely nothing. There's nothing that I would. Of course, I would never tell my wife to go to be a specialist and do anything else, because she's doing exactly what she wants to do, and I don't make any of those decisions anyway. So.
You last question. Like I say, I love your website. It's you have this diagram of the major evolution of specialty referral patterns from a dental office with 4 specialists to now all 4 specialists in the building. And you say most industry experts believe that over 50% of the $25 billion a year in specialty services are expected to be rendered in-house within GP offices over the next 10 years. Continued consolidation by DSOs will force remaining independent offices to integrate specialties to remain competitive with one-stop multi.
Absolutely. I mean, think about it. The cost of owning a solo practice is continuously increasing, right? So how do you offset your overhead expense? If you're closed one day out of the week, you're only working 4 days or 5 days out of the week, and you have an extra subset of 3 or 4 operatories during the week, or your office is closed, you might as well bring in an opportunity to optimize your practice and reduce your overall overhead. And so, and then if you look at the consolidation industry, right? So more and more practices are consolidating. Well, and especially within the DSO space, if they're financially backed, those individuals are wanting to make sure there's same store growth. So there's a couple ways of having same store growth. You can increase your number of new patients, increase your retention, but you can also capitalize on the referral opportunity and keep that in house. And so we are seeing a huge trend of consolidation, but also integration of specialty. I mean, it's a number one topic, right? When you go on to emerging and large kind of mid-sized DSOs, well, how do I successfully integrate specialty? And so we feel like that's the gold rush, right? That's the trend. We just kind of want to be the Levi's jeans that help support it.
Well, I think what you're doing is amazing, and I think it's well, I look at it like this. I'm on my way out, right? I had my 4 kids. They're now all independent. They've made 6 grandkids, and what I look about is you line up 10 dentists, you say, who's the best dentist? And they're all going to jump down and say, I have the most alphabet behind my name. I got my FAGD, MAGD, who gives a GD, diplomat, board shut up.
Yeah.
If my 6 grandchildren come in and they each have a cavity, and the first dentist can't convert any of them to do it, and the second dentist can't, and the last one converts one kid to fix his cavity, that's the best dentist. It's not the materials you use. I wouldn't care if you removed all the disease and filled them with butter, or margarine. It doesn't matter. If you can't increase your treatment plan acceptance, you're not fighting disease. And what you said at the beginning of the show, if you ever find a reference on that, when you said that,
Sure.
Oh my God, what was it? You said, what percent of
about 40% of patients actually go to the specialist.
So if my little Taylor Marie comes in there and says, you need a root canal, but you're gonna have to reschedule, go to the other end of the city, and it's next Thursday, and she's sitting there thinking, and it just doesn't happen. And if you want to be a quality dentist we talked about this earlier in it always. Anything a sapien can do to increase his vision. I mean, look at Galileo. I mean, just one little simple telescope, and he found four moons on Jupiter. Going from human eye to 2.5. I'm at 3.8. When it ended on us using
14,
a microscope. Well, a lot of my friends are only using 6 to 8 on a microscope. The anal ones, and by the way, if a dentist is OCD, remember he's anal about oral. And, so you might think about that a little bit. But the bottom line is if you increase magnification, you're going to do higher quality. But you're not going to do anything if the patient doesn't accept treatment, and that's going to take old retail stuff of evening hours and weekends and putting everything on one roof. And if you want to make them the most happy, I mean, look at Costco. It's all under one roof. Look at any Kroger store. It's all right there.
Howard, like to your point, I mean, that's what we found, right? So it's great. You want to now offer the service. But how do you have that conversation with the patient? How did you define it? How do you identify the patient? So we started actually, bringing on hygienists that help work in these offices and educate the teams on, okay, well, this is a patient who, there is a good candidate for orthodontics. How do you bring that up to the patient, right? So getting a little bit uncomfortable or getting comfortable by being uncomfortable in those conversations is critical. And so we found that is the first step, right? It's great. In theory wise, everyone wants to have in-house specialty. It's how do you do it? And we really want to be that how partner. And it starts at so many different levels. It's not just, I got a doctor, I'm not the match.com, right? I'm like, hey, I got a specialist, I got a GP, you guys should meet. That's not how it works. That's not how it works successfully. And so it really has to be coordinated and orchestrated well from start to finish. And a lot of times people forget that it really starts with that initial dialogue between the hygienist and the clinical RDAs and how they're establishing that conversation with the patient from the beginning. And that's what really the first domino to fall.
Well, I'll tell you what, it's been an honor to podcast you. His name is Santosh Patel, MHA, MBA. He's down in Frisco. He's one of those evil Dallas Cowboy fans, and if he had a heart and a soul, he'd be an Arizona Cardinals fan. But not everyone could be perfect. But his website is CompleteSpecialty.com, and if you want to be a good dentist, when 3 people come in with a cavity, you fix 2 of them. And remember, and this is what I've seen in dentistry forever. People like me, if a doctor told me you need to have a colonoscopy every 5 years, I'm like, well, I'm a dentist. You're a colonoscopy. I'm going to do what you say. I don't want to die of colon cancer. When they told me when I turned 50 that every 10 years I'd have to have a brain MRI to look for stuff, well, I'm a dentist. If you say that, I'm going to go. 1 out of 3 are going to do it because they do an author search in the library, and colonoscopy guys should know about your yin yang. Oral surgeons should know about your wisdom. And 1 out of 3 aren't going to do anything right in their whole life, and it's probably half of your entire family reunion. I mean, they know they're not supposed to smoke while they eat butter, but they don't care. They don't want to wear a mask, whatever. That's our crazy sapiens, and I love them. My favorite patient is the one who's on, when I get to the office, she's on a motorized cart because she's too heavy to walk, and she's on an oxygen tank, and she's smoking right by my front door and takes the last puff. And I'm pretty sure you're not supposed to smoke by an oxygen tank.
Yeah,
I mean, I might be wrong, but I'm just thinking, but she's adorable. And so 1 out of 3 are going to do everything you say. 1 out of 3 will never make a right decision in their life. It's that middle 1 in 3 where if you make it easier, if you explain it in simple terms, if you put it all under one roof, and if you do same-day dentistry, say, well, you know what? Santosh, you haven't been in here for 3 years, and we just did your cleaning. You got this one little cavity, and I'm afraid if you go out that door, it's going to be another 3 years, and then you're not going to need me. You're going to need a root canal. You're going to need to end it on us. Can we just do this today? And then Doc says, well, we don't have a room after we had a 42% adjusted production and a 25% staff and a 10% lab and a 6% supplies. We don't have an operatory. Dude, get a bigger facility. Understand your cost, and that 42% adjusted production they're not doing to the specialist. So make it faster. I say if you're playing with a full hand, hold up your hand. If you're playing full hand, it's faster, easier, higher quality, lower cost, and smaller. And if it's not all of those things, you're not a good doctor. If the dentist across the street, every time 3 people walk in the cavity, he fixes one, and every time 3 people walk into your office with a cavity, you fix 2, you're twice as good as a dentist or a doctor than the guy across the street that's not treating any disease because he can't present it, collect it. He's not getting it done. It'd be like a fireman saying, well, I'm the best fireman in the world, but I ain't ever seen a fire. I'm the best policeman in the world, and I've never caught a bad guy. I mean, come on. So go to CompleteSpecialty.com. Santosh, it was an honor to podcast you. Please tell your wife I said hello, and I'm so sorry that you're married to a dentist. My sympathies.
Thank you. I appreciate that.
All right. Have a great day, buddy.
You too. Take care. Thanks for having me.